there.
He is not for the uninitiated. You know, you
No,
have,
no.
it's like you're juggling 12 balls when you're trying to figure out what the hell he's saying. Pardon me.
Yes, and I can,
Yeah.
I speak Halassa, so I can distill it down to you in like 1 minute.
That's amazing.
Understands the value of energy and muscle and quickness and all those type things, and spends a lot of time swimming in the hormone arena and attends the regular meetings on Monday, which I think they spend a lot of time focusing on hormone discussions to ad nauseum, maybe with Halassa's on every week, right? Dr. Halassa, who we love. With
Yes.
that, feel free to take the screen, share, fill us with your knowledge, but at the end of the day, let's get to some basic recommendations on how you get there.
Yeah, so that's great. Thanks for the introduction, Dr. Lewis. I also have my colleague here, Lauren Gillespy, PA. She works with me at Iron Direct Primary Care, and she's really devoted herself to treating female hormones at this practice. That's where her passion lies. So she has a lot of wealth of knowledge. So the way I'm going to start this lecture first is I'm going to give you kind of a high level, but also a very practical overview of this. And this is part of a course I'm creating for practitioners who want to learn this sort of things. So I can give you kind of a preview of this. This is week 3 of this course I'm creating.
Excellent.
So we're going to go through some of the literature and then some of the really nitty-gritty stuff.
And then one thing, I'm not saying it's a myth, but there's perceptions out there. I had lunch with one of my biggest clients, the CEO thereof, and she said, I'll never do hormones because everybody on bioidentical gets cancer. That's her belief structure. So it's like,
yeah, and that I understand where that's coming from.
oh, we lost your audio.
Sorry, I'm back.
Okay.
Right. Our FDA chief, Dr. Makary, whatever his name is, he just said that whole thing where hormones were suppressed and told to cause cancer is probably the greatest mistake of modern medicine. And that's what he said really just this past week. He's trying to remove, and I think he has successfully removed the warning labels on estradiol creams at the FDA. And so that's a huge move. And that's probably what brought a lot of attention to this. And that's probably why you brought me on this show, is because now we have a lot of patients asking, well, why haven't I been prescribed estradiol if now the FDA says it's safe? So let's talk a little bit about this. Why replace estradiol? We do it at the practice here as routine part of primary care. We're a primary care practice, and within that, we do hormone replacement therapy as casually as you would, prescribe a statin at another office or a blood pressure.
Oh! I get the analogy, but never say that prescribing a statin. It takes me so much energy to convince people, no, no, no. So I know you were just saying it from an analogous of how frequently it's prescribed, but
the thing is, so much energy in regular practices goes into blood pressure lowering, statin prescriptions, metformin prescriptions. At our practice, hormones come first, because if you can optimize the hormones, a lot of those other things improve. We know estradiol prevents cardiac disease. It improves arterial pliability because the artery is essentially a collagen, and it stiffens with age, it hardens. So when you have arterial stiffness and hardening, it increases blood pressure, it increases risk of heart disease. So if we have a way of modulating that from a root cause perspective, and what's more root cause than replacing estrogen in a postmenopausal, perimenopausal female? Because estradiol goes essentially to 0 when you're postmenopausal. If this happened to men, I mean, this would have been a nationwide epidemic. It would have been on the news every day if this was a men's problem. Men, you can get away your whole life with testosterone at around 600 total, and it doesn't always decline with age. But with women, unfortunately, estradiol gets shut off like that. So what happens? They develop osteopenia, osteoporosis, bone fractures. And then estradiol is cognitively protective. It protects against white matter atrophy. It protects against vascular dementia, of course, because it improves arterial pliability. It's anti-inflammatory. Women feel better on it. And then most practically, it prevents vaginal atrophy. So it can prevent urinary incontinence, recurrent UTIs, dyspareunia, which is pain with intercourse, skin dryness, and frailty with age. So this is all reasons why estradiol should be replaced as routine part of primary care. Every primary care in this country should be doing this. Across the world, they should be doing this. But unfortunately, because of some early studies that have now been looked at again, a lot of misinformation got out there and women thought it causes cancer. But we will get into the estrogen and cancer a little bit later. So this is the estradiol levels during one menstrual cycle, and they go up and down all throughout the cycle. This is during a premenopausal woman. Their estradiol goes up super high, and then it goes down super low. And so typically, maybe they might peak at around 200 or 300 picograms per ml of estradiol during day maybe 22 of the cycle. That's really when we try to measure it in women premenopausally, is we send them in for a blood draw at around day 21, day 19, day 22 of the cycle, so we can see their peak estradiol level. Postmenopausally, it's gone. You really don't detect it. Now, get this. If you measure a woman in pregnancy, their estradiol can go super high. We're talking 30,000. I saw one the other day, 30,000 estradiol level in pregnancy. Now, mind you, the peak that you could achieve naturally in a young woman is maybe 200, 300 plus. 30,000 in a pregnant woman. And pregnant women are perfectly fine. They don't get cancer. We don't worry about an estradiol level of 30,000 in a pregnant woman.
Definitely, I've got to put my foot in my mouth. But if you ever have seen 30,000 estradiol in a former vice presidential candidate, just saying.
No.
Say it, Michael.
Oh, hell yeah.
I couldn't keep a straight face,
Right.
It's the macho.
Yeah, exactly.
So how do you replace estradiol? What are some practical ways? You can inject it, estradiol valerate, it's commercially available. You can take it orally. We don't really like to do that because there might be some issues with liver conjugation. Maybe you can do it sublingually. Topically is fantastic. You can do pellets, of course. We don't really do them much at the practice, just because we like to be able to microdose it with topicals. And topicals are great because they're versatile. You can put them on the neck. Felice Gersh, she's a great lecturer. She comes on the Clearfield and Halassa show a lot. She says you can put the estradiol around your eyes. It helps as an anti-aging wrinkle cream. So it helps locally. You can put it on the vaginal area. I've been very successful in helping women with pain with intercourse, vaginal atrophy, and urinary incontinence with intravaginal suppositories of estradiol hormone combos.
Has anybody tried formulating estradiol in DMSO to get absorbed through the skin?
So yeah, that's really interesting. And my mom actually, I think she reads the same things you read on subreddit or whatever. She actually brought that up with our local compounding pharmacist, Tuan. He had never heard of that either. He's like, well, we can do it. We can do anything. So that's a great idea. She brought that same thing up. So that's brilliant. So things that you should be monitoring is the estradiol to progesterone ratio. And you can calculate this, you can put it on a calculator, and you can get this ratio. And you want to make sure that a young woman is cycling their progesterone and it's coming up during the luteal phase. Very often in our modern society, young women are not cycling their progesterone. And this is a huge problem because without progesterone, you don't have a human population. Progesterone maintains the endometrial lining. It helps maintain a pregnancy. Women will have a miscarriage if their progesterone doesn't go up. But it's a real unspoken epidemic. It's young women they'll have estrogen or they'll have estrone, and Halassa will talk a lot about estrone. And they may have estradiol, it may not be super high, but they won't have much for progesterone. And this puts them in what's called an estrogen dominance. And some people in functional medicine, they don't like that term, but that's what it is. Halassa likes to call it an estrone problem because estrone is probably a little bit more problematic. It's a bit more inflammatory. It is proliferative. Well, estradiol is anti-inflammatory and proliferative. And the proliferative is good. We hear about proliferation and we think of cancer, but if you don't have proliferation, you shrivel up and die. You need proliferation so that you have new skin cells every day, so that you have eyes, you have epithelial cells in your eyes. So that's really important. You shrivel up without um, cells dividing. But we want to balance it, and progesterone helps balance it. So whenever we prescribe estradiol, we balance it with progesterone as well. It's very simple. You give a woman progesterone 200 milligrams at night, and they start sleeping again. It's amazing. As Dr. John Lewis knows, you can order labs, but you want to measure all the appropriate labs. So this is a basic female panel you'd want to order. You want to check your vitamin D, your full thyroid panel, your DHEAS, your pregnenolone, estradiol, DHT plus or minus, not super important for a woman unless they're younger and they're having some PCOS symptoms. LCS, total and free testosterone, very important actually. Women need testosterone just as much as men. It helps with all the things it can help with for men: libido, bone density, muscle gains, weight management, cognition. So women need testosterone too, not as much as men, but they still need it. And then progesterone, of course. Now, progesterone is interesting. If you prescribe women progesterone, say it's 200 milligrams, they take it at night, helps them sleep, they feel great, they love it. You measure it the next day in the lab, they don't have a detectable progesterone. You're like, well, where'd it go? Well, it's probably out of the system by the time you measure it. And so serum progesterone levels aren't entirely useful. You might detect some in the blood, but it's not a great test. I usually just dose progesterone based off how they feel. If they're sleeping, great. There might be better ways to test it. Some suggest urinary metabolites. Some will just salivary, which we're going to get into a little bit later, and the problems with that. So,
Stefan, why do you measure? Go back a slide. I already forgot what I was going to ask you, but you can go back. Why are you measuring cortisol instantaneously?
yeah, you're right. Serum cortisol is fairly useless.
I think if you take it at the right time of day and you kind of correlate it, that's okay if they like draw it first thing in the morning kind of thing. But
yeah, the best is salivary, but it's $4. It's cheap. You can get a cortisol level in the morning, but I'll show you salivary. It's way better.
Sure. Okay.
Let's see. So we'll skip some of this. This goes on a little bit about women with high estrogen and how to help them detox this. So you want to make sure they're getting enough fiber into the diet. They're avoiding a lot of the junk food out there, the fried oils, a lot of xenoestrogens. You want to make sure their liver is detoxing well. So maybe you put them on N-acetylcysteine or DIM detox. You make sure they don't have fatty liver. So if they're not detoxing the estrogens appropriately, you can have a problem. And then I'm a huge iodine fan. I brought iodine to the table with Dr. Halas. It's in all of our protocols here because iodine, it's anti it's an anti-neoplastic. It prevents cancer, and you can prevent a lot of the estrogen dominant symptoms from happening by giving them topical or oral Lugol's iodine solution. So this is fibrocystic breast disease. This is painful menstrual cramps. Even in men with tender breast nipples, give them iodine, and it will help inhibit the estrone accumulation in these sensitive areas. And of course, the diet is super important. My friend, Dr. Paolo Conforti, is an Italian functional medicine doctor. He stayed with me here a couple weeks and saw patients with me. He doesn't give hormones to women unless they've done everything else right. He says hormones is a gift. You need to be doing the exercise. You need to be eating right. You need to be getting sunlight, grounding. Because if you give the hormones and they're not doing everything right, maybe they're going to have some more problems. They're going to have more side effects. So he says hormones are a gift. I'm a little bit more liberal with hormone prescriptions here. I think everybody needs them regardless of their lifestyle. They're going to feel a little bit better and maybe they can then incorporate some lifestyle changes. But definitely you want to make sure you're getting enough nutrients so you can metabolize things correctly and avoiding, plastics, Teflon, aluminum, scented candles, perfumes. All these are xenoestrogens. If you're spraying it on your skin, it's getting absorbed into your bloodstream and it's mimicking estrogen. They're toxic estrogens. They're forever chemicals. They mess with your endocrine system. You don't want to be putting them on your skin. Anything fragrance, I hate it. Now, these are some other things that we just talked about that you can do to help women metabolize estrogen, both postmenopausally and premenopausally. Testosterone for women, we mentioned that a little bit. Very important for libido, preventing frailty, helps with low arousal. Optimal levels, there's a lot of, if you go to these functional medicine conferences, you get a lot of different opinions as what is optimal. I say Optimal is wherever the patient feels best at. And in the blood, they may have a free testosterone of 3. They feel great. Maybe they feel better at 6. Okay, it's a little on the red in the lab reference range for women. Maybe a woman feels great at 200 testosterone. If they don't have virilizing side effects, and virilizing is deepening of the voice, hair growth, they feel good at 200. They like to be a little bit more assertive, a bit stronger. Okay, you can let them ride a little bit 200. Now, other people are a lot more sensitive to it. They're like,
When you say 200, are you talking
total.
total, not free,
Total.
obviously?
Yeah, total of 200. Yeah.
Just clarifying, that's all. Yeah.
Yeah, I had a woman recently, she was injecting testosterone cypionate. She was at 600. I was like, well, that's a little bit high. You should probably reduce that dose. She's like, well, I didn't notice any side effects. I'm like, yeah, you could probably feel just as fine with a lower dose. Maybe you should inject a little bit less. So you got to work with your patients there. Some like a little bit more. DHEAS, super important. You can sometimes improve a woman's testosterone just by giving them DHEA. You can give them, if they're low, like low is below 100, very low. You want optimal between 200 and 300, 350. Too much DHEA, you're going to get acne on your skin like you're a teenager again. Too low, and you're going to shrivel up like a prune. You're going to have dry skin. Your skin is going to be brittle. You're not going to have that skin barrier. You're going to get dehydrated. How many times do you see a patient 80 years old come into the ER for dehydration? It's all the time. Lauren can tell you, she works in the ER. It's like every night. It's dehydration, frailty, falls. It's what happens with older age. But with hormones, this can all be prevented.
Let me ask you a question on the young end when you talk about acne.
Yeah.
Is there a way to obviously measure, but then balance hormones to affect, really this chronic profound acne that it usually uses like drugs like minocycline for a long time to treat or others?
Oh, minocycline is an antibiotic. No, we prefer other ways to help with
No,
PCOS.
no, I wasn't saying the minocycline. I'm saying some people they used to use that a lot.
Oh
Is there
yeah.
a way? Is there a way to just balance hormones and change that
The
that syndrome?
great the great irony and joke of society is men have low testosterone and women have high testosterone now. It's super sad, but it's the case. It's endocrine disruptors. And
Yeah.
it's our job to warn patients about avoiding endocrine disruptors so this doesn't happen. And then in functional medicine, it's a huge battle to correct this. It's every day men with low testosterone and then young women with PCOS, which is higher androgens, higher DHEA, higher testosterone, and then lower progesterone. So it's a whole flip-flop that has happened. And so we need to balance it. And then with older age, DHEA, again, it declines. And so that's where you want to replace it so that you're not super dry. And it's part of my protocol for reversing and regenerating vaginal atrophy. So I do DHEA, estradiol, and testosterone as a suppository. It works very well. Pregnenolone is a super important one for your memory and cognition. It's the first hormone that comes after cholesterol. You need cholesterol to produce all your hormones, so we don't want to crush cholesterol entirely. But pregnenolone is very often deficient or even absent with age. And so without pregnenolone, you don't have any of the rest of the hormones. You don't have cortisone, you don't have cortisol, you don't have estradiol, testosterone, DHEA. You really don't have these hormones. Now, replacing pregnenolone and replacing DHEA as precursors won't do anything for a postmenopausal female. They won't convert to estradiol suddenly, right? You still need to replace estradiol. But pregnenolone has effects positively for the brain and memory. And then DHEA has its own benefits for the bone and the memory and the heart alone. So they're
Just looking at your chart, Stefan. Can we give people cholesterol? There's a product called Sonic Cholesterol,
yeah.
which has as much cholesterol, actual cholesterol molecule as one large egg in a pill.
I mean, yeah, it's not going to convert into the hormones, though. You still need to prescribe the hormones.
Okay.
So here's how to prescribe it. You can start low and go slow. Some people are very low. They need a higher dose, so you need to do the labs. Pregnenolone might help with sleep. DHEA, you really don't know what it'll do, really nothing. You don't really notice it. Some do notice that pregnenolone helps with sleep, though. So, how do you know what is optimal? We get that question all the time. So the best way is to have a historical trend from when you were very young. So age 15, you should be testing all your female patients, your daughters, your children. They should get tested so you know what it looks like to have optimal hormones. The next best is to test your daughter. So this is what this mom did. She's age 57 and her daughter is 19. And they did a side-by-side comparison. So you can see who is who quite easily here. On the left, you can see low thyroid function. Her free T3 is 2.7. That's mom. And here's the child, age 19, a free T3 of 3.8. So robust thyroid hormone. Very good. We can look at, let's see here. We are looking at total testosterone and free testosterone. So daughter here on the right, you can see a free testosterone of 3 and a total testosterone of 59. And this is very good. This is very healthy level. She feels great, good muscles. Here's mom's total testosterone 31, free 1.6. It's actually not that bad. You can already see she's having some glucose abnormalities, probably from lack of hormones. She's starting on the dysmetabolic syndrome already. Pregnenolone on the mom is 53. And pregnenolone on the daughter, do I have that? It's around here somewhere. Let's look at the estradiol. So mom's estradiol 38. I think she was doing a little bit of estradiol at the time, a little bit of hormone replacement therapy. Daughter's estradiol 141 on, again, luteal phase, mid-luteal phase. Daughter's DHEA without supplementing 491, and no acne, mind you, just that's natural DHEA in a young woman, and that can be normal. Mom DHEA, she has to supplement to get to 267. Look at the growth hormone difference. Daughter growth hormone 224. Mom's IGF-1 111. So already getting in the low range there, where the child still has robust growth hormone. And let's see what else here.
Interesting though, comparison.
Yeah, just comparing the two here.
Progesterone, she was 1.
Yeah.
And
Oh yeah, that's right. Progesterone very low in the mom. Daughter 5.1. Actually, that's kind of suboptimal progesterone. We would like to see ideally a progesterone maybe up in the teens, maybe 16, 20 for mid-luteal phase. So maybe seeing some issues already here. So when you start prescribing hormones, what do you do when a woman starts getting her period with HRT? So if you ask Dr. Felice Gersh, she's an anti-aging guru, she's lectured at all A4Ms, she is an OBGYN, she does a uterine ablation. Now, the reason she does uterine ablations is because she has her female clients cycle their progesterone. So she actually will induce a bleed in the postmenopausal females on purpose because she believes that estradiol has a proliferative effect, which is good, but progesterone has an anti-proliferative effect. So it actually inhibits the benefits of estradiol. So she has them do progesterone day 15 through 27 of the cycle, has them stop it, and then has the bleed. This is a hard sell. Me and Dr. Clearfield, we've never been able to sell this to our patients to tell them to have a bleed. Most women don't want to give up their progesterone because it helps them sleep. They have less anxiety. They feel better on progesterone. So I'm not going to have them go half the month without their progesterone. The flip side of this is that theoretically, there is a bit of an anti-proliferative effect. So you may not get the full benefit of estradiol if Felice Gersh is correct. But the benefit of doing continuous progesterone is that you won't get a bleed, you won't get the maybe the overgrowth of the uterine lining that could potentially happen. So there's a plus and minus to that. Most people in functional medicine, they don't have their women cycle progesterone. Right? They just do continuous progesterone therapy, and that's perfectly fine as well. And we're not all OBGYNs who can do uterine ablations to stop uterine bleeding. Yeah, women will get a uterine bleed if you do high dose estradiol therapies. It's going to happen. And they're going to get scared and they're going to run to the OBGYN, and they should be doing a regular pelvic exam anyway. They're going to do it, and the OBGYN, they're going to do an ultrasound. They're going to say, nothing's wrong, you're perfectly fine. They can go home. And I mean, they should be doing this regularly, but it is something that can happen on occasion. Take a look at the power of estradiol on the skin. This is a patient who was really holistic, and she actually worked with colloidal silver. Her job was like making this stuff, but over the years she developed a terrible autoimmune condition in her hands. Her hands were clawed up. She couldn't even open her hands. It was terribly painful, and she had tried all these steroid creams, but the steroid creams that she went to the dermatologist for, they were eroding her skin, so her skin was getting super, super brittle and thin. If she bumped it, she would bleed and scrape. So she was postmenopausal. She had no hormones. I put her on topical estradiol. I had her basically wash her hands with estradiol every day. And within a matter of a few months, we completely regenerated her hands.
Wow. That's
Right.
impressive.
Right.
Beautiful.
Yeah.
Okay.
And so it's a visual representation of the power of estradiol. Think about that inside your arteries. Think about that internally, right? That's what the power of estrogen is doing for you. It's regenerating you. So what dose is right? Is there a wrong dose? What labs to check? We get all these questions every day, all the time. Take a look at this lady. She was having dyspareunia, which is a medical term for pain with intercourse. She couldn't have sex with her husband anymore, so this was really affecting their marriage. We tried a topical estradiol. Oops, I flipped a lot of pages there. We did a topical estradiol, and it really didn't move the needle. You can see on the far right column here on the top left corner, the testosterone really wasn't therapeutic with transdermal application of testosterone. Same as the estradiol. We were doing 1.5 milligram of estradiol topically, maybe moved the needle from 7.4 up to 71 or 39 with estradiol. Really wasn't moving the needle, still having pain with intercourse. And I said, well, all right, that's enough. Let's get you fixed. Intravaginal estradiol, 2 milligrams per ml, plus testosterone, plus DHA, plus pregnenolone. We shot her estradiol all the way up to 692. Maybe overshot the mark a little bit, but she now has regular intercourse, painless with her husband, saving her marriage. And she feels great, regardless of what the numbers look like. I talked to her recently and I said, well, you want to reduce the estradiol? She's like, I feel great. Why would I change it? I said, well, the numbers shows you're a little bit high. We should probably, if we want to treat the number, reduce it. So I prescribed a 1 milligram. So we'll see what happens next. I said, if things revert, you go right back to the 2 milligram estradiol. I have no problem with a high number. And she loves taking progesterone every night. She doesn't want to stop doing that. So when you get a progesterone, when you get estradiol, you have to make sure you're not getting equine estrogens and you're not getting synthetic progestins because they're not the same thing. All right? These are the ones that potentially can cause clotting, right? They can cause strokes, heart attacks. This is what the studies found early on, that there was an increased risk of strokes and heart attacks by giving equine estrogens to women. But despite that, there were still some positive benefits for like osteoporosis and things like that. So there were still benefits, but we now do bioidentical hormones. We get it from a compounding pharmacy typically, because I found that the commercial pharmacies like CVS, they do these baby doses of estradiol. It's like a patch with 0.025 milligrams. It's like nothing. It's a drop in the bucket. I had a patient on it the other day. She came to me and her estradiol level was like 5. And it's like there was no change. So if you're a regular primary care and you're super scared about hormones and that's the best you can do, great. A 0.025 milligram estradiol patch twice a week. But if you're a real anti-aging wizard like us here, you do a real dose of estradiol. So this here is a salivary hormone analysis. So there's another anti-aging guru named Dr. Pamela Smith, and she swears that the only way to measure hormones is with saliva. She says any other way is useless. She's pretty authoritative on that. However, she is sponsored by a lab company, and she gives a lot of talks to them, and their test is this test. It's a salivary hormone test. So there may be a bit of a conflict of interest there. But it is fairly useful because you can do it at home. You just fill the tube full of saliva, and you can measure it and you send it to the lab and you get this result. Here's a female. She is 45 years old. She's perimenopausal, night sweats, fatigue, insomnia. She's drenched, wakes up at 2 or 4 a.m. She can't sleep really. She's been trying to improve her diet, but it's not helping her symptoms. We can see in the saliva, her testosterone is undetectable. It's less than 5. Her estradiol is undetectable, essentially, right? 1.0 is really not detectable. She has a little estrone, right? The pro-inflammatory, proliferative, the problematic estrogen she has. And she doesn't have any progesterone either. And her cortisol is actually a little bit low on this graph too. So what did we do? We give her estradiol. So we give her a topical cream. We gave her a biest. And so that's another thing in anti-aging medicine, biest, estradiol. I'm of the mind that estradiol is good enough. It's going to convert to estriol, I should say. It will convert to estriol. There is one, it's either Pamela or Smith or Felicia Gers. They say, why would you give estriol to a woman? That's what they have in pregnancy. You don't really need to give them estradiol. Just give them estradiol, and the rest will do the trick. And I think that's essentially true here. As we can see, her estradiol did come up, and it's a completely different unit of measurement. So we're used to seeing in the blood a serum estradiol of maybe 160, maybe 60 or 80 with replacement. Here, you're going to get different measurement, a unit of measurement. So we see it's like 6.2. But if you look at previously, she went from 1 up to 6.3. Salivary is a very sensitive way because it measures the free amount of hormone in the test. This is very useful. And you can also get a measurement of progesterone very sensitively as well. So this is probably why Dr. Pamela Smith says saliva is the only way to test hormones, because if you want to get a level of progesterone, you're not going to see it in the blood. You probably only see it in the saliva. And we also see an improvement in her testosterone with this treatment. It's a really nice topical combo. She's doing very well. She lost 13 pounds. She's sleeping 8 hours a night. She hasn't had any night sweats or PMS issues. She says she's never felt this good mentally or physically overall, like in years. So a very happy case here. So this is a little bit more. This is another lady. She's 63 years old. She's had poor sleep for 20 years on amitriptyline, GERD, asthma, hypertensions. After the lockdown, she went up to 253 pounds. She's had gastric bypass even, was at 180 pounds. So she's gained a lot of weight despite gastric bypass perimenopausally and postmenopausally. So we did some testing here, and let's see. Yeah, we could see we did hormone replacement therapy. We did estradiol 1 milligram, testosterone 1 milligram. We can see a nice change here. She went from estradiol of 3.1 to an estradiol of 79. Her total testosterone went from 6.4, which is very low, to a total of 49. Her free really didn't change that much though. And her pregnenolone went up. And she says her fasting glucose come down. Let's see.
When you see a free that low, do you put them on some sex hormone binding globulin modifiers like boron or things like that?
I mean, you could just increase the dose of testosterone, but
Sure.
she started feeling better. Her, she's not taking her blood pressure meds anymore. She did get a little bit of breast tenderness, probably from converting to estrone a little bit. So we put some iodine on there, and that improved. But we were able to discharge all her medications. We got her off of her asthma medications, her Advairs, her albuterols. We got her off her amitriptylines. She'd been on this for sleep, but once we got her on progesterone, she didn't need amitriptyline. It's like a junk medicine. We got her off of amlodipine since her blood pressure resolved. She was on another puffer of asthma because her asthma resolved. Her losartan, we got her off of that because her blood pressure resolved. Montelukast, got her off of that because her asthma resolved. We also got her off her GERD medication, her omeprazole. We did a whole gut protocol on her.
I'm sure.
So yeah, we fixed a lot of things for her just with hormone replacement therapy in about 3 months. And she had these problems for about 20 years. Let's see. Maybe.
Now, hypertension after delivering your last child. I see that a lot.
Oh yeah, this one.
Mm,
Yeah, well, there's a lot of reasons for that, but one reason is because prolactin will go up when you start breastfeeding. And prolactin turns off all your hormones. Without the hormones, women can feel pretty bad. They can feel depressed, anxious. They can start getting autoimmune activation postmenopausally. I mean, post delivery of child. So a lot of things can happen, and I've actually been known to actually give women hormones postpartum just to help them feel better, and they do feel better when you do that.
mm.
Let's see. This one, hypertension since age 45 after the blood is very holistic. Likes to get herbs for treatment. They're very resistant to hormone therapy. And I get a lot of these patients. They're super naturally, they're like proud of not taking any medications. Like, I don't take any drugs. I don't want to take these hormones. Then I get them on the hormones and like, oh my God, I sleep way much better. I feel better, but my bones don't ache so much anymore. And so this is my patient population is supernatural people who are kind of proud to a fault for not taking any medicines. So this is another one. She's 60-year-old female, naturally minded again, very proud of not taking any drugs, but she was using alcohol at night to sleep. Whiskey, taking shots of whiskey every night. No progesterone, of course, right? Gone, less than 5 in the saliva. Estradiol, actually had a little bit of estradiol at age 60. So what did we do? We gave her progesterone. And so she slept and she didn't need to drink alcohol anymore. So we got her off of alcohol. Huge, right? Let's see. Let's skip some of this.
Dr. Carter and I are not getting rid of our Malbec. We don't care what you say.
Exactly. Exactly.
This is a screenshot from one of the Tuesday lectures with Clearfield. Testosterone and breast cancer risk. So when you give women testosterone, decreases their breast cancer risk. And there's some really cool studies being done on women with malignant neoplasms in the breast, where they'll insert a pellet of testosterone near the neoplasm, along with anastrozole, which is an estrogen inhibitor. And they will see just with that therapy that the tumor will shrink up. So pretty cool stuff
Yeah.
they're doing here. So the lowest risk of breast cancer is in testosterone-treated patients as well. This is something that Dr. Clearfield found. So we're going to open it up for questions with Lauren and myself here. If you could read off in the chat if there's any questions, Dr. Lewis, we'll answer.
There's not. I will make one. Lauren, do you want to? You can unmute and chime in. And
Okay.
do you agree with everything Stefan said? No, I'm just kidding. If you have anything else you want to add, because sometimes the ladies want to work with the ladies. So
They do.
Sure.
feel free to tell us about what you do.
Okay. My name's Lauren. I am a PA. Been a PA for almost 5 years. I have background experience in emergency medicine, and then I became very passionate about functional medicine, more so hormones in females with my own personal journey with PCOS, my own hormone imbalance. So I know you kind of asked a question about I guess adolescents with acne or we see
Yes, I was
pretty
going to ask.
commonly. Yeah,
Yeah.
we see this so common. I I think primarily the cause of that is a just from experience and just from testing their labs, but is a relative estrogen dominance. And unfortunately, whether it's the birth control or the just the disruption in their luteal phase. I often put them on inositol and DIM, and it can almost immediately correct their acne in about a month to 2 months.
What about a male? What about a male that's on nothing, not a great diet, but just has, that real acne
Yeah.
that can lead to cratering?
Yeah, and it's very oily. That's often with the aromatization of the estrogen. So it's really eliminating those xenoestrogens, fixing his diet, and then, seeing what his DHEA and his DHT levels are.
So you're
Maybe,
recommending the full hormone panel that you guys do for
yeah,
someone like
almost
that.
getting him on DIM. I've actually have a patient right now. I have him on DIM right now, and he's improved significantly. I mean, he's had lesions, like cystic, deep lesions on his back, craters almost in the jawline. And, it's really debilitating for these patients. They've been on Accutane maybe twice now. It just comes right back. Yeah. So, with the males, I often do a low dose DIM. But you have to be careful because we don't want to completely, disrupt their estrogen metabolism. But it can be a little bit more difficult with males. I mean, I'm primarily focused with females, but maybe Stefan has some recommendations with male acne. But for females, it's often extremely common. And I'm going to add to that female hormone panel, but I always check an LH FSH. We always want to check a ratio of LH to FSH. If we're seeing anything greater than 3, all my patients go on inositol and DIM. I mean, they're just not ovulating, probably. They're probably not ovulating. They're having some luteal issue because of that. And then I may do some cyclic progesterone to fix the luteal defect if we're not seeing any improvement with the inositol. So
That's very interesting.
Now you putting the males on inositol and dim as well for
I
that?
I do not do that with the males. Okay.
Oh, so
Okay.
males
Only
that.
low dose DIM with
Oh,
the males. Okay.
gotcha.
Okay. Mm-hmm.
Yeah,
Low dose, like
I had
100 milligrams.
I had a very
Yeah.
severe cystic acne male patient case. I did that salivary hormone test. He had very high estrone, and so I put him on anastrozole actually. And
Uh-huh.
anastrozole was really the only thing that helped his acne.
Oh, gotcha. Okay.
Yeah.
So,
Okay. Yeah, I forgot about that. Yeah.
What,
Okay.
what I'm learning from this dissertation today is that hormones, the range is pretty wide. There's a lot of different opinions, but I think what people really need to do is work with someone that has experience, because this is,
Yeah.
we're dealing with what we call at MIT factorial math. You get the pregnenolone, you get the DHEA, you get the progesterone, you get the estradiol, you have the testosterone. That's 120 combinations, when you talk about one times two times, factorial math, one times two times three times four times five, balancing all these things. I mean, I look at it as just give me some tea, help me boost my tea.
That's why you
And
see all
and
these.
off
That's
I
why,
go.
that's why you see all these TRT clinics everywhere. No one wants to do this. No one wants to do real primary care. You don't find
Yeah.
that everywhere.
What's TRT clinic, Stefan?
Testosterone replacement therapy clinics, they pop up everywhere.
Yeah. Okay.
It's easy.
Yeah. Easy peasy. Just give me the teasy.
But
Yeah.
doing primary care like we do, no one does that.
Yeah. No, it makes a lot of sense. Dr. Carter, I would entrust him. I entrust you guys. I have yeah, I have you guys have experience with acne. I have a female and a male. I'm going to send you guys, because you have that experience. That's what we need. I've done everything I can do on diet and things like that, just not making any headway. But this is not, a little zit here and there. This is like
right,
Yeah.
exactly.
you don't want to go out in public, you know.
Yeah.
They're embarrassed by their presumed disfigurement. So that's really, really good advice. But
We have some
yeah,
questions in the
I'll,
chat.
I'll 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 ask you guys a question and I'll make it you know, let's see. What so Lauren, what percentage of females that you deal with you think need to have hormone evaluation and adjustments? That's
Honestly.
yeah. I mean, seriously.
Um, I would say 99% of them, excluding my 19-year-old on birth control whose mom won't let her get off of it.
Yeah. I mean, see,
Yeah,
like I
they
said,
all have. the relative what so what is what is so prevalent, because I feel like I'm primarily focused, what's more complex for female hormone imbalance is that population that's between 18 and up to the perimenopause. Perimenopause is complex as it is, but no one wants to really focus on those hormone imbalances that we're seeing in our post-pill PCOS, any of our PCOS patients, anything adrenal PCOS related. And to be honest, it's our diet in the US, it's so flooded with hormones. It is extremely prevalent with young girls in their 20s who they can't get a period. I mean, they can't get a regular period. It's not like how when my mom was in high school and everyone just had periods. I mean, it's a daily struggle, and our local OBs and primary care is just their only solution is birth control. And I see it every day. I mean,
Yeah.
and they start to lose hope because they don't want to get off the pill. They don't want to have the acne. They don't want to do Accutane again. They don't want to have those terrible cramps. They don't want to be called that they're crazy because they have PMS. I mean, it's a really debilitating issue.
Wow.
And
That's
um, I'll say the the simplest way to just step one, whether we're primary care, OB, whatnot, um, when we get off the pill, is just start them on inositol and dim. I mean, it can go a long way. It really can. And it's really, there's a huge disruption between you can look at that LH to FSH ratio and you can see immediately that they're not ovulating. And when you don't ovulate, your progesterone has an issue cycling. So your progesterone can't spike in your luteal phase. And so it's just like step one is you got to try to get their ovaries to start ovulating. You got to try to stimulate that again because
and what age range is this suggestion advice most appropriate to?
I would say um any age really until they hit menopause.
Uh-huh. Yeah.
So I think in the perimenopausal phase, that's where you really see a prevalence of that proliferative, that inflammatory estrone dominance. You see those females who they go through, they're like, it's like menopause just hit them with a wall. Their progesterone trickles and down, and then all of a sudden their hormones just fall it and they plummet. And they get that estrone just sticks around and they get so inflamed. And so that's when in that perimenopause, DIM can be extremely beneficial. Obviously with optimizing their hormones with estradiol or progesterone at night because they have no progesterone at that point. But DIM can be really beneficial in that perimenopausal phase because we're just seeing such um, a prevalent imbalance with that estrone dominance. So
My part B question is, if you're done with that, is, I'm really weak in this area, but tell me about heavy bleeding. And
yes. So menorrhagia. Yeah. So often with menorrhagia, that's again what we more so see with a estrogen dominance. It's what we see with a relative or a frank estrogen dominance. So relative meaning your progesterone is zero and your estrogen is there. Frank meaning your estrogen is high and your progesterone is not high enough. So when we see that, that's when we tend to see this excess bleeding,
Mhm.
and they often tend to be very painful. And so if they're still getting pretty regular cycles, a great way to do this if they're in this perimenopausal phase is to do some cyclic progesterone. And I tell them because these these females, if we're perimenopause, I mean, it is extremely uncomfortable. Their hemoglobin is probably on the borderline of a transfusion. I say you start progesterone 100 milligrams at day 10, and you take it until you get first day of your menstrual cycle, so first day of bleeding, and then you hold it for 10 days, and then you'll resume again on day 10. Um, and and that really just helps to alleviate that imbalance. At that point, DIM can be really helpful as well, because often with that, you see that estrogen dominance, just what I've noticed from experience. But the progesterone, when we see these heavy periods, progesterone is almost always the answer. So I don't know, Stefan, you have anything to add with that, but that's what I typically tend to do with my patients.
Yeah,
Yeah.
I think it was Dr. Clearfield that told me that progesterone, for lack of a better term, will dry them out. So it will dry out the bleeding, and it's dose dependent, and they may need a higher dose to stop that bleeding.
Mm-hmm. Mm-hmm.
Very good. Good. Excellent.
Go
Excellent.
ahead, Michael.
No, excellent presentation. No,
I mean,
very good. Very
it was,
good.
it was right on the money, guys. I
Yeah.
mean,
Absolutely.
we need this. I'm going to post it right away because I have a half dozen people that need to listen to this. Yeah, yeah. And I really appreciate the one too. Let me ask you guys a question you don't have to answer. Who's the MD that you operate under?
Dr. Goodman?
Is he local to your area?
Yeah.
Okay. Just don't know. Just curious.
Yeah, he's a pain management guy.
Got it. Okay.
There's a couple questions here in the chat. Did you see any of these?
No, I haven't. Am
I
I
see
looking
it.
at the Oh,
There's a
my
ton of
goodness, I'm not in the main chat. I'm duh. They changed the chat view and I can never so yeah, I missed it. So if you want to read them and take a look.
Yeah, I looked at a couple. Let's see if there's any really good ones here. Let me see. Oh yeah, someone talking about the Dutch test. Yeah, so the Dutch test is expensive. It's about $400. I don't use it to dose hormones. I don't use urinary metabolites to dose much of anything. I want to look at least blood or even salivary. The Dutch test is a good way to see how someone's excreting estrogens, right? So how is their metabolism of estrogen? But I wouldn't never dose hormones off of a urinary metabolite. So, um, let me see. Yeah, some questions here about Dr. Carol Peterson's in the chat. And Dr. Mike Plax says that high levels of morning cortisol correspond with high adrenaline. Yes, that is true. We know that. Yeah, seen that. Someone, Doug Leonard, Doug Leonard in the chat. 71-year-old postmenopausal female with history of hypothyroidism and thyroidectomy on HRT, ovarian tumor, hypersecretion of testosterone with bilateral oophorectomy 2024. Have you seen elevated testosterone in postmenopausal females? The chief complaint is dyspareunia. What workup would you recommend and resource for the patient to support those recommendations? I would do a full hormone evaluation. She most likely is deficient in several key hormones. It's probably why she's having vaginal atrophy. So she does need to be replaced. She's 71. You can replace hormones at any age. You don't need to qualify by, getting it early. It's not too late at age 71. Right? There's no one's too far gone. Progesterone can mitigate acne. Yes, Carol Peterson is a huge fan of progesterone. She's a regular lecturer in the Halassa chats. Someone says, this is for young women. More power to them. Now almost 80. Feel great. Good physically, mentally, sleep well. Marriage is better than ever. Sex, question mark. That ship has sailed. Thanks, Lewis, for these
I
programs.
laughed at that. I laughed at that one. That one, yeah.
No one's too old. I mean, I know I had this one lady, she's age 63, and she had written off ever having a boyfriend. And we got her on hormones, and man, she was interested again. She got a boyfriend, and she was living life again. But the problem was her boyfriend dumped her, and then she had all these urges with no outlet. And she actually stopped the hormones for that reason. I'm like, don't stop the hormones is good for your heart, your brain. I mean, I know it's
Right.
great for other things, but I used them to help prevent, atrophy of your brain. The side effect was you have more libido. Wasn't really the
Right.
intended effect.
Yeah.
Yeah.
If a woman went into menopause at age 50, did wild yam hormones, E3, progesterone, now 63, has osteoporosis. Folks discuss, yeah, we don't do wild yam hormones. We do bioidentical, usually pharmaceutical grade estradiol. The osteoporosis at age 63, I mean, you're looking at bisphosphonates, Prolia infusions in a conventional medical practice. But if you come to a functional medicine practice, it's not too late. Again, they say, did you miss the 10-year postmenopausal window? No, there's no window. That's a myth. I think that came from some
And
bygone.
I'll say for osteoporosis, make sure no root canals, teeth are good, and take some boron. You
Right.
know, those are a
Nutrients.
couple of things you can go on, beyond what you talked about.
Nutrients, hormones, and anabolic steroids. Yes, say it with me. Anabolic steroids. We use anabolic steroids here at the practice, and they are great and indicated for osteoporosis and osteopenia, right? Nandrolone,
So
oxandrolone.
I'm ignorant on this, Stefan. What's the difference between testosterone and anabolic
No,
steroids?
testosterone, DHEA, pregnenolone are all anabolic steroids.
Okay, okay.
But
Yeah, I thought,
then you can get synthetic ones like oxandrolone, nandrolone. They are great for frailty and atrophy and osteopenia, osteoporosis. We use them all the time for that. Yeah. Someone said I have a male patient, age 69, submucal oral progesterone. Um, yes, he's sleeping better. Yes, you can use progesterone for men as well. It works for sleep. Halassa, he'll sing the praises of progesterone intranasally with cyclodextrin all day for you. You can use it intranasally. You can use it submucosally. You can do it orally. It will work.
hmm.
Yeah.
Is that falling asleep or staying asleep?
Yeah, so that's the key. We found that intranasal might work quickly for falling asleep. Staying asleep is another story.
Yeah.
That's where things maybe like growth hormone might work a little bit better, right? Giving yourself a unit, 2 units, 3 units injection intramuscular growth hormone at night works wonders for sleep. Someone said, "Can you explain the patient with the claw hands?" Yeah, I'm not sure. You need to get evaluated by us. I'm not sure what your condition is here, but that was a that was a very specific case there.
Yeah. So what he's saying, so you need a workup.
Yeah, you need to work up. Yeah.
Workup. It's
Could
not
estradiol help with arthritis in the hands? Yes, hormones. All hormones need to be balanced to prevent and treat arthritis. All hormones.
Mhm.
Yeah, especially estradiol. Yes, it helps with collagen synthesis. It's anti-inflammatory. That's all the questions.
Once again, Stefan, I think much appreciation from the audience and myself for the presentation today and the clarification. I'll
Yeah,
have to listen to
great job.
Yeah, it was a great job, but still, me personally, I'm gonna have to listen to this several times. I still go back and listen to Dr. Clearfield's lecture, and what I got to do is take better notes and really commit myself to it. But this was a big help. And Lauren, thank you so much for your passionate presentation on female rectification. I think that was a very, very helpful segment as well. So I thank both of you folks. And
Excellent.
look at that, we're right on time for the first time in modern history.
I
So
give a
with
quick lecture.
Yeah, and for that, because of that, I'm going to actually work on the number one recovery method independent of everything else. A good night's sleep.
Oh,
Terrific, Stefan. Thank you very much.
sure
Very
thing,
good.
guys. Anytime.
All right.
Talk to you later.
Okay.
Bye for now, guys. Take care.
All right.
Bye.
Bye-bye.